Hello, everyone, and welcome to this lecture on the seminar series on advancing maternal health, innovations, and collaborative solutions. This is a collaboration between IIT Kanpur Medical School and the University of Melbourne, where I am from. My name is Dr. Farnaz Sabet. I am a family physician, and I also have a PhD in adolescent and maternal health, and I'm currently a researcher in the field of adolescent health, focusing on adolescent maternal health. I'd also like to acknowledge the collaboration with my colleague, Dr. Esha Chatterjee, who's presented previously or presented in this seminar on unwanted fertility. So the topic of our two talks is around tackling challenging pregnancies. So she spoke about unwanted fertility and how that impacts pregnancy and outcomes, and I will speak about adolescent pregnancies. Now, what are adolescent pregnancies? Basically, girls who become pregnant from the ages of 10 to 19. We estimate, or there's approximately 13 million girls who give birth annually, and 1 million of them are in India. Adolescent pregnancy is known to have poorer outcomes, particularly with younger age. This includes higher death in newborn babies. Because of these poor outcomes, for decades, the approach to tackling this challenging pregnancy is to prevent it. But obviously, we still have 13 million girls who become pregnant every year. So some of the thinking needs to also go around, how do we support these girls to decrease their poorer outcomes? Now, in India, where I did most of my research, child marriage is illegal. However, the enforcement of law can be weak, and there are many exceptions to its practice. One of the challenges around early marriage and pregnancy is that married women or married adolescents are perceived as women. This is by society, but also by NGOs and service providers. So you might have, for example, a sexual health program targeting adolescents, but it would rarely target married adolescents. So these girls really miss out on key education for their health and are really at high risk for becoming pregnant and having poor reproductive outcomes. Also, we know that access to healthcare is limited for adolescents, in particularly married adolescents and pregnant adolescents. And when they do get to care, they are often given poorer healthcare because of the stigma surrounding them, and also because of what I've termed as or acknowledged to be intersectional discrimination. Girls are often from rural settings, poorer families, lower caste families, and the lower age all compounds to give poorer quality medical care. So just to highlight the different thinking in providing adolescent pregnancy care. So most of our work in adolescent health has been around multiple pregnancy risk factors, decreasing those risk factors so girls do not become pregnant. This is a very key area, and that's what you want to do. However, as we know in medicine and medical practice, we also treat people who have the outcome. So we've rarely done this in adolescent pregnancy care. We haven't looked at, well, we know outcomes are poorer, we can prevent adolescent pregnancy, but we also can see how we can optimize medical care to improve outcomes both in mother and child. And that's the focus of the collaboration that I had with my Indian partners. So I want to go to where we collaborated with and where we learnt from the immense experience that India has in another field in maternal and newborn child health. And that is women's groups practicing participatory learning in action. So this is an approach of learning where women or the community comes together, has 4 phases. They identify and prioritize problems, they plan strategies, they put the strategies into practice, and then they evaluate these strategies together. This has now become a regular monthly group facilitated by the ASHA, who's the government incentivized healthcare worker. And so it's become part of government health services in many states in India. This is an example of a PLA women's group in rural India. It's very open, anyone can attend, and it's been linked, it has a good source of evidence around it, which I will go through now. So ECCHUT, which is a civil society organization based in Jharkhand, ran the first cluster randomized controlled trial in rural India on whether these women's groups affected neonatal mortality, that's death in newborns, and they found an overall reduction of 32% in the neonatal mortality rate. There was then a meta-analysis led by University College London from various sites of these cluster randomized controlled trials that affirmed this reduction. There was article in the WHO Bulletin that again showed that this was an effective intervention. And finally, in 2021, there was an article in the Lancet Global Health that showed even when these groups were facilitated by accredited social health activists, that's the government healthcare worker, they still led to a significant reduction in neonatal mortality, and even more so in marginalized groups. Such is the evidence around this intervention that it's a WHO recommendation for low resource settings with high burdens of neonatal mortality, and it's become a recommendation in 10 states from the National Health Mission of India. So here you can see some of the states, and I imagine since this slide was done, even more. I want to acknowledge the partners who are ECTRID, who have led the training of the facilitators, who have led the rollout of this program and ensured its quality and follow-up. And they were key. So in a sense, there was immense experience in this area from ECTRID. So I want to now highlight why the collaboration between University of Melbourne and ECTRID was beneficial for both. Because I am a researcher based at the Centre for Adolescent Health. It's part of Melbourne's children's collaboration, which is the Royal Children's Hospital in Melbourne, the Murdoch Children's Research Institute, and the University of Melbourne. So globally, there's very little expertise in adolescent maternal health. So it's something our centre also doesn't have expertise in, but we have expertise in adolescent healthcare. And we were open to bring that expertise to those partners in India who had immense expertise in community maternal and newborn healthcare. So together, we were able to tackle novel and interesting questions and identify new solutions to how to enhance antenatal, prenatal, and postnatal community healthcare engagement for adolescents. So we undertook a study together in a very collaborative way, looking at pregnant adolescent engagement with participatory learning and action groups. So as I highlighted before, we have lots of evidence for these groups that they reduce death in newborns, but we also know that pregnant adolescents have higher newborn mortality rates. And then in many of the places where we have participatory learning and action groups, rural states with high burdens of neonatal mortality, we also have a high burden of adolescent pregnancy. So you can see how this interconnection, this overlapping of the condition really made this question very critical. And it was our thinking in adolescent health and their thinking in participatory learning groups, when these came together, that we were able to identify really important questions. So going back to this picture that I showed before, of course, you're familiar with India. You know that Bihar, UP, Jharkhand all have high rates of adolescent pregnancy, as well as all the other factors that make PLA groups with women very effective. So we wanted to see these groups are effective, but are they working for this subgroup, which is pregnant adolescents as well? So if you take the state of Jharkhand, for example, it's a rural state, if you look at their adolescent fertility rate, it's 73 births per 1,000 adolescents, where the national rate in India is 43 per 1,000 adolescents. So one way of tackling the high neonatal mortality rate, which in this setting is in some places almost double what it was for adults, based on the data we looked at. So you've got an intervention, women's groups practicing PLA, and then you have a group that, the intervention is working to reduce neonatal mortality, but you have a group, adolescents, that have higher neonatal mortality than adults. So it's really important to see, do these groups work for these girls also? So this is us doing the research together, observing groups, looking at how the young girls participate, especially the pregnant young girls. Do they feel confident to share in this space? Us in University of Melbourne with years of experience around adolescent health, certain questions that we were aware from a developmental perspective of the adolescent. And of course, our Indian colleagues, very much understood the context and the local culture, but also had certain blinkers on in terms of how a married adolescent is perceived. And we were there with different perspective on whether and how the pregnant adolescent was developing as an adolescent. So, in the methodology, it was really fantastic that we could come together and do this. So, there was local ethics, which was important because we had lots of tribal representatives on the local ethics committee, and they were very clear about important questions that needed to be asked that we, as an outsider, were a bit hesitant to ask, but they really emphasized and encouraged that they were important. And then we had the University of Melbourne ethics, which also was helpful because it brought a lot of rigor to how we stored our data, how we did our consent process, where we stored our data, etc. The study design, the key questions, the stakeholders, the sampling strategy, including the need to sample different casts and different backgrounds of girls, that was determined by ECTRID. They're the people that really know what are the key things we need to be asking in this setting. The data collection was jointly done, which again brought two perspectives to the observation. The transcription and translation was organized by the University of Melbourne, but checked by ECTRID. This was really taking a burden off ECTRID. They're there to implement programs. They're not there to do the nitty-gritty work, which we can easily take on. And both ECTRID and University of Melbourne researchers familiarized themselves with the transcripts, but it was the University of Melbourne researcher, which was myself, that did the nitty-gritty of coding, which, as anyone doing research in this field knows, it takes a very long time. So we took that time. But the final themes were determined by a joint consultation, which brought multiple disciplines and perspectives to our interpretation. Sociology, medicine, anthropology, rural settings, urban settings, India, and globally. And actually, the global perspective I felt in terms of interpretation of this study was important to see, well, what are the elements we can learn from what you're doing in Jharkhand and India that is useful for others around the world that might not be in the exact same circumstances, but is similar and can benefit from this experience. So it was helpful to have both. Our participants, we had 29 interviews, 9 focus group discussions with 104 unique participants, of which 26 were pregnant adolescents or adolescent mothers. A snowballing approach, and we soon realized that we couldn't determine if some of the challenges for pregnant adolescent engagement with groups was because they were adolescents or because they were just pregnant for the first time. We had personal experience of pregnancy, and we knew that becoming pregnant for the first time itself was challenging. So we decided together that we would have to also interview adults who were pregnant for the first time who were coming to PLA groups to see what the difference was. We also had to interview adolescent girls who were not married and not pregnant who were coming to the groups to again see, is it just being an adolescent that causes the challenge, or is the unique combination of being pregnant and an adolescent that causes the challenges they had with the groups? So I want to share some of the findings, just some key findings with you to see, to share how novel the question was and how interesting the findings were. So we interviewed an adolescent having a pregnancy and an adult having pregnancy for the first time in these rural villages. The adolescent really had very little knowledge of what to do. Like I shared before, that they hadn't really even received any basic sexual health education. So the 15-year-old prima gravida said, I don't know. I don't know anything. I'm new. I don't know what to do and how things are to be done. I don't know what we have to ask them. So as we did our interviews, we would say, is there anything you want to ask? And very consistently, the adolescent would say, can you tell me what I'm supposed to be asking? I mean, that was the level of maturity and development and even knowledge. Another adult in her having miscarried her first and now going to term with the second, shared this about her engagement with her health providers. I feel scared. Where do you feel scared? I feel scared in the hospital. I've heard that the madame beats you. You are scared that madame will beat you, so you will not go to hospital? Yes, I will deliver at home. So here we had a young, high-risk pregnancy refusing to go to the hospital for fear of how poorly they treat adolescents. Now let's take the adult. The 24-year-old from Gravida. It's very rare actually in this setting to find someone who is having their first baby at this age. We said, "How was your delivery?" The adult responded, "It was very nice. The nurses were good. They did everything nicely and did not cause extra pain. It did pain, but birth does. Now all is good." The nurse said, "You'll have a bit of pain. Try to tolerate it." I liked coming to the SADA. One, too scared to even go, doesn't, and another one doesn't even know what to ask. And then you have the adult who had a wonderful experience. And this was not an exception, really. It was very clear that the pregnant adult had a vastly different engagement with health services, and it carried on also to the engagement with PLA groups, how comfortable they felt to share their ideas, how comfortable they felt to engage in a setting that required participation. So some other quotations that they shared was really about the loneliness that many of these girls faced. I don't have any friends. How can I go sit anywhere? I have to look after my husband also. I don't go out often. There is no one to listen to my grief. So this girl never went to a PLA group because she really didn't have friends. Critical, we knew, from the Center of Adolescent Health with expertise in adolescent health, that peer group relationships were important. So just to go to a group where you don't know anyone, you've married into this new village, you don't know the other people, is a big challenge for girls. So this was one barrier. Another one, which was we started to understand that the moderator in whether they went or didn't go into groups was the family. So if the immediate marital family was supportive, girls were generally okay, and the outcomes for the pregnancy for the girl and the newborn was okay. But if their family was restrictive and difficult, they had terrible outcomes, including newborn death. Um, and also, it was the autonomy around decision making. So many of these girls also related somewhat to Esha's talk previously, was that they really didn't have much choice in becoming pregnant when they were so young in their marital families. They'd married at such a young age. So just a overall summary of the findings. We have the pregnant adolescent here, PLA groups here. How well, given this group is really trying to target marginalized elements of the community, of which the pregnant adolescent is one, how well did they engage with the group? One is, yeah, they all wanted to go. They had a desire to learn and develop, but the family and community heavily influenced whether they could or not go. And here, the thing that could bypass this family influence was the Asha. She was very critical. You had a good Asha, she could enable the pregnant adolescent to bypass a very restrictive family and come to the group. If you had an Asha that wasn't tuned in to caring and supportive pregnant adolescents, they would just be left at home. The family support was the linchpin. That was the key relationship. Everything revolved around whether they had a good supportive marital family or they didn't. We're talking about marital family here now, because that is now the family she's in. This family could decide whether the girl was subject to the restrictive norms or not. If the family was supporting, she had more choice in whether she became pregnant or not. If the family was not supportive, she had a very heavy domestic workload, so much so that she wasn't allowed to go to groups. And then if the family again was very conservative, they wouldn't allow her to leave the home at all, including to go to PLA groups or including to even go to the healthcare center. So we really identified the critical role of the marital family, not only in being a barrier to her care, because we had many families that we interviewed that mitigated the social norms. That for the pregnant adolescent, there was one girl, for example, her marital family, her in-laws encouraged her to continue her study and sent her to another area so that she would continue studying while she was pregnant, so they could completely bypass these social norms. So it seemed that we had identified a little key that could unlock really traditional patterns within the village. They could go around them if the family was good. So we recommended that ECJUT and anyone working with PLA groups that wants to target and involve pregnant adolescents has to see how critical this relationship is, not as a barrier, but actually as a critical support for the girl to engage with groups. There was, of course, lots of limitations in this study. One is two of the field researchers were doctors. I mean, being a doctor, you always counseling people not to become pregnant at a young age. So we really had to stand back and say, we're here just to explore their perspective, not to provide any judgment. The research was done in Hindi, but of course, many of these girls were more comfortable in tribal languages. And again, the collaboration was helpful because Ekjut provides training for PLA groups, so they would always see the positive element of it. And then you had researchers from University of Melbourne or outside giving a very different perspective on, well, maybe she's expressive because of the relationship with her mother-in-law, not because of this other element. So again, that perspective, I think, in qualitative research is very important. So what did we find? What was the solution that we identified? Well, interestingly enough, unlike what, adolescent health researchers would assume, pregnant adolescents wanted to be with adults. They did not want a separate group for themselves. They felt that family support was critical. What they didn't want was no family support. They were alone. Of course, they wanted a supportive mother-in-law. Of course, they wanted a supportive sister-in-law to help them go through pregnancy. None of them wanted to be alone. So the key here was, how do we create that group setting that enhances her feeling of support from those within her family? Married girls did go incredible many restrictions that prevented full engagement, but the family influence on norms was much more dynamic than previously described. There was much more leeway. The social norms were restrictive, yes, but how much a family could influence and choose to follow the norm or not was really diverse. The Asha, again, I influence, was very critical to bypass some of these norms and could do so. So really training the Asha so that she can help the pregnant adolescent do this was important. And the involvement of men. We really found that many girls spoke to their husbands about reproductive health, and many of the husbands did not know how to answer correctly. And the crucial role of parenting in adolescence. So it was almost as if the mother-in-law and father-in-law were a pseudo-parent for the adolescent. Again, our collaboration helped in that because we know in the Center for Adolescent Health that adolescents are still developing and although they require less parental influence than children, they still require some guidance. And these girls were no different. It was not like once you become pregnant, your brain switches and you no longer need to develop and you no longer need any guidance in your life. So it's a very um, interesting conclusion about the role of the in-laws in the development of these girls. Oh, so we have an extra picture here. I apologize. So I just wanted to highlight in these pictures the useful role of collaboration. We had various perspectives, which I shared with you. We also, as the University of Melbourne, really dealt with difficult editors. I mean, publishing qualitative research is difficult. So having that big university structure, I'm sure you also have many of these in India, but having this collaboration meant we had lots of voices. Yes, our Indian colleagues felt that this research was important, but the Australian colleagues also said this is also valuable for the other settings we work in. And this gives a lot more strength when we're dealing with editors who are perhaps less reluctant to deal with qualitative research or contextual research that is important and critical, but they might feel is not globally relevant. So we really were helpful. This collaboration really helped to shift that. So I'd like to first thank you all for listening. It's my email. Feel free to get in contact. Like to really acknowledge the co-authors, which was a really good mix of both ECCHUT and the University of Melbourne, as well as University College London, and acknowledging that we had joint senior authorship from both, and of course the University of Melbourne. I look forward to more collaboration with you all, and I hope that this was interesting, and it was a pleasure indeed to be with you today. Thank you so much.